Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair at Appeal Academy and creator of Top Gun Audit School. We are live on the April 22nd, 2016 edition of Finally Friday. And I do want to thank everyone for choosing to spend your precious time with us here on Finally Friday. Today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide. One of our partners firms is Recovery Analytics. That's Sharon Easterling's company. She does auditing and education, often authors articles for AHIMA as an AHIMA fellow, and she is a co-host on the show. Finally Friday is now also sponsored by Meddlings Cost Containment. They're the makers of Healthcare Audit Tracker. You can visit zerodenials.com today to see how they can help you track audits and greatly reduce or even eliminate denials. And our newest sponsor is Mass Coding Solutions, a leading healthcare consulting firm with over 25 years in the medical coding industry. They have core competencies in medical coding solutions and medical coding education. Please keep an eye out for notices that we'll be sending out soon about the recordings from their ICD-10, easy for you to say, Ernie, ICD-10 Coding Connection Conference, which is chock full of 2-hour sessions on ICD-10 coding and auditing. I'll be sending out notices about how you can get those soon. And no, they don't pay me to, I don't get anything from you purchasing any of those. It's just because I believe in them. And finally, we're also partnered with the Council for Certification of Medical Auditors, the CCMA. They are the creators of the widely used Certified Medical Audit Specialist, or CMAS certification. And we are very proud that we've been approved to offer CEUs for all our shows for CMAS certifications. Okay, today we are happy to have with us our special guest here to talk about the key things a hospital needs to know about the confusing and problematic new definitions for sepsis. Our guest is Dr. Eddie Hugh. He's Medical Director of Case Management and a Physician Advisor at Rex Hospital, part of the UNC Health System in Charlotte, North Carolina. Dr. Hugh graciously consented to do a review of the pitfalls of this new sepsis definition today so that our audience can freely learn what's going on and what you need to watch out for as a result of this new set of definitions, which did not come from CMS. And of course, I also have my loyal and faithful co-hosts on hand, Sharon Easterling, who's an auditor, speaker, writer, and appeal writer. But actually, I'm not sure if she's going to be able to be on with us today because her husband just got out of surgery. So I think that's a little more important than the show. We'll see. Maybe she's able to join us, maybe not. My other co-host, Bill Mom, who's a practicing physician assistant, speaker, a writer, and certified medical auditor. And he's managing director of his own company, Health Revenue Integrity Services. Bill is again calling in from the United Kingdom, where he's doing some work on population health management. Bill, I see you on the list. Were you able to get on the phone there?
I got on, Ernie. I'm here.
Oh, okay. All right, great. Good. So the international calls are amazing to me how clear the connections are. So anyway, thanks to everybody for joining me. Now, before we get going, I do want to make clear that the opinions shared on this show are those of the panelists, not necessarily representative of their employers. My opinions are also my own and probably no one else's, especially not those of our sponsors. Okay, so before we get started, I want to switch over to the website because I believe we have a good number of people on today who may be new to the show. So let me find the website. There we go. By the way, if you haven't heard it, you want to go and listen to our theme song. It's under Fun Stuff on the Appeal Academy website. I can't play it back here because the audio won't come through on the line. But anyway, I recommend you go look at it. If you are new to the show, I want to tell you that what you do is you go to Appeal Academy, any page on Appeal Academy, and you scroll down, and on the right somewhere you will see this box with the green buttons. If you click on that, it will open a new page that will show you the meeting controls overview. That's so you know what to do with those green buttons at the top of your screen. There you can find out about how to connect audio either by internet or by phone. Those instructions are on that button. There's another one. The second button from the left is the chat box. I highly recommend you open that during a show because we often have another conversation going on in the chat box. And by the way, that box is not recorded. The only thing that's recorded is what you see on the screen inside the Join Me window. The chat box is not recorded, so there's no chance of anybody discovering anything out of that later. It is not copied. I do want to recommend everybody, please keep that professional. There are all kinds of people watching the show, physicians, nurses, everybody, so please keep your comments professional and on topic. And let's see what else. Oh, there's a zoom button, the big one in the middle, so that if I'm not zoomed in enough on something, you can zoom in by yourself and zoom in on the screen. I do remind you, though, that you're the one that has to zoom back out if I go to something else. Participants list is the second button from the right. You are listed as usually you're the one at the very top of the list. If you hold your mouse over the U, then you can actually type in another name, your name or nothing or whatever you want to do there. Some people do it, some people don't. If you look in the participants list, you can see that. Up to you. It's just so that people can talk directly to you if they want to. Because you can talk to one person or everybody all at once. You might want to pay attention to who you're talking to if you send a chat message. More options. I'll forget those. I'm not going to give you control of the room. That's for my panelists. Anyway, so what else? Let's see. Okay, I do want to tell everybody, if you haven't figured it out by now, Finally Friday is kind of informal. It's a discussion, not a lecture, so please feel free to enter any questions you have at any time in the chat box. My co-host and I will handle the questions as best we can, try to answer everyone's questions or respond to their comments in the time we have. We have an hour, so we usually do pretty well at that. To be frank, we sometimes go over a few minutes just to let you know. All of that will be recorded. A recording is available usually a few hours after the show, and then there's another format that I'm going to start creating. The same people seem to have trouble playing back the format I used. Let me see. We already got a question in the chat box. Let's see, Dr. Hugh, I think we will cover this. Since the new definitions for sepsis are not allowed by Medicare, well, I don't know if that's true, and the core measure definitions of sepsis have been approved by CMS, why should we use the newer definitions of sepsis presented today? That's a very good question. We actually had something like that sent in before the show, and we're going to talk about that in a few minutes. So hold on to your hats, and we'll get to that. Okay, let me get back to the slide deck, and we will get going. Okay, a few things before we get to talking to Dr. Hugh. Last week we talked about reporting and returning overpayments final rule. That was where CMS basically decided to hire all of you as extrapolation experts. Forget about being able to just send in the payment for a denial anymore. You now are going to have to do some more work, and the fear is that that's going to involve extrapolation, and you actually have to defend that to CMS. Anyway, that was last week. We're going to talk about that more in the future because it really bothers me. I don't know if it bothers you. Another thing is I promised last week to get this webinar up. I'm behind. Sharon already did it. Got the recording ready to go, and we will start broadcasting on Monday. That's where Sharon gives a very in-depth view of how you can set up an ambulatory CPI program in your hospital because it's becoming more and more important. Okay, so this week we are talking about sepsis. We're talking about these proposed definitions versus what's the clinical reality of how you deal with sepsis. And it reminds me of a poiute, you know. You look at it one way, it's got 4 legs. You look at it another way, it's got 3, except in this case, we're dealing with something that's deadly. So that's the impetus of the show. Let me get to a few things about the news. There really wasn't that much news this week. And by the way, the news is soon going to be sponsored by the CCMA, Council for Certification of Medical Auditors. And so there's going to be like a little newsletter that we will send out once a week. that will talk more in depth and have more news in it than we were able to do on the show. So that's coming soon, and that's because of the CCMA. So watch for that. Anyway, in the news this week, I said this was an informal show, so we kind of have some fun. And so I got a few slides that are just fun. And thanks to Bill for reminding me and telling me that the Queen turned 90 this week, which makes her the longest reigning and oldest British monarch ever. And I think that's kind of pretty cool, although I'm not much into monarchs. But Bill's from the UK and he's working over there, so I had to acknowledge it. Right, Bill? Anything you want to say?
Absolutely. It's a big week over here for the Queen, for any of the royalists.
Okay. Yeah, I think it's going to be, it is a big deal for them. Big deal that anybody turns 90. Frankly, that's what I think. Other cool things that happened this week, Rogue One, the Star Wars story trailer came out, and if you're not a Star Wars fan, then you won't care about that, but I do. Another thing is that HBO's Game of Thrones Season 6 premieres on Sunday. I'm a fan of that. Maybe you are too. I think that's a big deal. The other big deal in the news was that Prince died a few days ago, and I had not heard of this before. I always thought of him as a big musician innovator, and I didn't realize what else he was involved in. He was actually involved in a lot of charitable causes, but he wouldn't let anybody talk about it because of his faith. He was a Jehovah's Witness. And what we heard on the news yesterday was this, which really inspired me. Prince was always telling his friends, look, whatever you're doing, level up. If you don't know what that means, that's a gamer's term. If you play online games, you're always trying to reach the next level. And that's an incredible line. I think it's highly inspiring. So anyway, I just wanted to mention that and give a small nod to Prince for that. Anyway, the one big news this week was that CMS published the IPPS proposed rule for 2017. There's the link to the Federal Register version of it. Basically, the big deal that everybody seems kind of confused about is the idea of a lot of people seem to have read this and they thought, oh, the 2 midnight rule has been dropped. No, the rule wasn't dropped. The only thing that was dropped was this minus 0.2% offset that CMS applied to all the hospital reimbursements when they applied that. And I just published an article. Let me get over to the site, show you. I did just publish an article that's a preview of, we will probably do a show next week that will be about this. So here, if you go to the Academy blog and then click on it, it's the one at the top. Here's my article about how they're dropping that, but there were no changes in the 2 midnight rule. It's a classic case of misunderstanding. As I show by this image, your car does not have email and bacon, but looking at it, you may think that. The goofy thing is that no matter what, I would bet that minus 2% is in some of these other proposals anyway. Minus 0.2%. So I don't think we're really getting it back. I think they're going to take it away some other way. It just won't be called that. You know, that's a common corporate kind of thing. They hide things one way or another. So, all right, so let's get enough about that. We will talk about it more next week. Now, we are going to talk about sepsis. We did a show back in March that was originally about sepsis when these definitions first came out, and we talked about it. And I went through and did some slides because I did research on the history of sepsis. It became very interesting to me because this is a very old diagnosis. It's been around for about perhaps 5,000 years. So, you know, why are we having trouble with it? Because it defies categorization. It has diverse clinical manifestations. I'm just going to quickly go through a few of these slides before I let Dr. Hugh talk here in a minute, because I did these before, but maybe you didn't get to see them. Here's some articles about the history of sepsis, going all the way back into Egypt. Here's one that talks about it in Greek literature. The earliest written report of sepsis actually came from Egyptians. This is like one of the oldest known physicians in the world. This guy, I'm no idea how to pronounce his name. I forgot that. I forgot to write it down. Anyway, that's his name. That's a picture, a possible picture of him. And it goes back all the way back to possibly 3000 BC and references 48 cases of that. So this is something that's been around for a long time. To me, it's just, hey, this is why you were always told as a kid, don't let that get infected. Here were some, sepsis was actually in Homer, in the Iliad, and it was also mentioned in the Hippocratic Corpus. So it's very old, and then there were also some other references to it back in the Middle Ages. Here's where it was mentioned, and again, you can go see some of those if you're interested in it. It was very interesting to me, so that's why I put it in. I see somebody's, okay, people are getting, we had somebody in the chat box who couldn't get the audio. Okay, so hopefully they're getting on that. Dr. Hurd says, yeah, such pessimism. They are even giving back 3 years of the 0.2% cut. CMS is occasionally nice. Well, I don't know that I buy that. But yes, I am a pessimist about that. But that's okay. That's just my opinion. Okay, so the three definitions that have happened in recent years started from a 1991 consensus conference, where they came up with some initial definitions of the then prevailing view of sepsis. And, at that time we had SIRS and all of that, so there were some definitions, but it was still a very complicated subject. Here's a link to that original article if you were interested in seeing about that. That was in 92, was published. Then in 2001, there was another one, and I think this was published in 2003. Anyway, it was the second definition that tried to make up for some of the problems in the first set of definitions, but even that had issues. So then we get to this newest one that was published in, was it published in, Dr. Hugh, no, I'm forgetting it. This was published in 2016. So this was done like back in February, is what started all
right.
this.
Second half of February in JAMA.
Yeah. And there's the link to the original article about that. So the problem is that gives us three definitions. There are really two that are still in use, and that seems to be a real problem. So it's 25 years ago recent. Okay, well, it was recent for, who was doing that at the time? I forget what I was talking about. Okay, so anyway, the problem is there is a difference between the definition and clinical criteria. So now I'm going to let Dr. Hugh talk about that, because Dr. Hugh, tell us about, what this Sepsis 3 now is the newest one, and so we're no longer using SIRS plus some suspected source as a definition. And the problem is, how does that stack up with real clinical criteria?
Yeah, well, thanks, Ernie, and it's a pleasure to be here. Sepsis 3 is confusing for a lot of different reasons, and I just wanted to take about half a minute and just talk about Sepsis 1 and Sepsis 2, which you had showed. But the Sepsis 1 and Sepsis 2 definitions were basically written by the same folks, 25 years removed, or people that work with those folks. And so Sepsis 3 was developed actually to replace both Sepsis 2 and Sepsis 1. We can certainly think of there being three definitions, but in actuality, the expert panel, their intent was to get rid of Sepsis 1 and Sepsis 2 and make Sepsis 3 the definition. And if we have time, we can talk about some of the other definitions that are out there. There are actually many definitions of sepsis, not even Sepsis 1, Sepsis 2, or Sepsis 3. But the expert consensus panel that defined Sepsis 3 did something very interesting this time, and interesting viewers can actually go to YouTube and find the videos of the presentations down at the SCCM Society of Critical Care Medicine conference in Orlando that happened contemporaneously with the release of the new definitions in JAMA. But what I wanted to stress was that Sepsis 3 really makes a distinction between the definition of sepsis and the definition of septic shock and the clinical criteria for sepsis and the clinical criteria for septic shock. So sepsis and septic shock now have new definitions, but the problem is they're not clinical definitions. And Dr. Deutschman, one of the two lead authors on the Sepsis 3 document, clearly stated at the SCCM conference that these definitions are the definitions. They are meant to help guide future research and to improve sepsis care in the future, but they are not clinical definitions that can be used today. So the definition of sepsis, for those that have looked at the article, sepsis is now defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And that's it. So, I mean, you don't see SOFA, you don't see QSOFA in the sepsis definition, because the sepsis definition is really that one line that is geared towards guiding future basic science research to try to better identify markers that can be used to identify sepsis, as well as treatment modalities that can be used to treat sepsis.
Right. So it didn't require those tools, but it did suggest that they be used, or that they would help to improve the mortality rate somehow.
Yes. So the sepsis panel could not just leave the definition at basically a one-word description of what they feel is happening at the cellular level. They needed to provide something, some kind of a tool that clinicians could use to help identify patients. And what they ended up doing was they turned it over to what they refer to as their younger investigators, who have a lot of energy and a lot of access to tens, if not hundreds of thousands of patients' data. And since the definition of sepsis is now predicated on this life-threatening organ dysfunction, they asked their newer colleagues to then go back to the data and try to identify a group of patients that have higher mortality. So that's really where SOFA and QSOFA come from. SOFA is actually not a new creation. It was actually created by one of the sepsis authors, Dr. Jean-Louis Vincent, I think in Belgium, who's been a long-time expert in sepsis and shock. And he actually published the SOFA criteria back in 1996 and showed that the SOFA score steadily rose in patients who got sicker and many of whom ultimately died of sepsis. So what the expert panel did this time was they looked at three different criteria. One of them is the familiar SIRS criteria. The second one is the SOFA score. And then the third one is the LOD score, which is a more complicated organ dysfunction score for sepsis. And they compared it with their large databases and said which one of these criteria really predicted mortality in these patients that were labeled as having sepsis. And what they found was that the SOFA and the LOD score performed about the same, but they were both superior to SIRS. So that went along with the opinion of the expert panel that SIRS was really not useful, and so therefore SIRS was written out of either the definition or the clinical criteria. And then the SOFA and the LODs, they chose SOFA because SOFA was so much easier than the LOD score. And so in the 2015 clinical criteria for sepsis, the panel proposes a SOFA change of 2 points or more from baseline to be the clinical correlate of the organ dysfunction, the life-threatening organ dysfunction that actually is in the sepsis definition.
All right, hearing you talk about it, it actually makes more sense to me than I've heard before. Okay, so and it seems to me like what they were trying to do was give a new tool that would be more readily useful or easier to use or quicker to use, and you don't even have to run these tests in order to use the QSOFA. Am I right?
That's right, Ernie. The SOFA criteria does require several laboratory tests, and so they looked hard for something that could be done at the bedside. And so they actually developed a new criteria that had not been previously described called QSOFA, which was based on three bedside assessment measurements. So you look for systolic blood pressure of 100 or less. You look for a respiratory rate of 22 or higher, and altered mental status. And that can be done in the ED. It can be done anywhere in the hospital. And having 2 out of 3 being present suggested a much higher rate of a poor outcome. the Q Sofa was purposefully developed to not require any complex assessments, really just a bedside altered mental status examination, count the respirations, look at the blood pressure. It does not require a lactate. The panel found that lactate did not improve the performance of the Q Sofa criteria. It doesn't require any other laboratories as well. And it's something that you can do at the bedside, you can do in the hospital, you can even do it in the ICU. However, in the ICU, the Q Sofa was felt to be a little bit less predictive, largely because of all the things that we do to patients in the ICU. We sedate them, we put them on the ventilator, we control the respirations, and so therefore, the measurements of the altered mental status and tachypnea are less relevant in an ICU setting.
We had somebody making a comment that the chart seems to indicate that the Q Sofa and Sofa criteria are required in order to use the diagnosis of sepsis.
Which chart?
I think they're talking about this one, where I showed the old versus the new.
Yeah.
Sofa
I mean, what you're
Sofa.
showing here is really the clinical criteria. And if you look, if you read the original article, the clinical criteria are listed right below the definition, and it really is hard to distinguish between the two because you have essentially a non-clinical definition, and then you have clinical criteria that are technically not the definition, but the best that the panel had to offer. So I think what is going to happen is I think most people are going to look at the clinical criteria as sort of a pseudo-definition for sepsis.
Okay. So let me see. I wonder if I can pull that article up. Let me see if I can talk about. Well, there were some other. I'll look for that in the meantime. But there were some questions that you had in your article, and these were the. Once you talk about these questions for a moment, and then we're going to talk about the suggestions that you put together in talking to people. But these are the kind of questions that you might have about it, right? It seems to be left open.
Right, Ernie. And the article that Ernie's talking about is an article that's published on the website of the American College of Physician Advisors.
Right.
It's a what is sepsis article that got posted on the website a few weeks ago. And because the SOFA score is so central to the 2015 clinical criteria for sepsis, there are actually many unanswered questions that the panel kind of danced around a little bit, but did not specifically come out and answer some of the real-world questions that people are going to have when it comes to application of the SOFA criteria. It's not answered in the Sepsis 3 document. It's not answered in the accompanying documents in JAMA. It's not answered in the accompanying articles that came out in SCCM a couple of weeks later. But they are questions that folks have started to ask of the expert panel. So, one of the questions is, well, when do we calculate the SOFA? If you look at the original SOFA paper by Dr. Vincent, they calculated a SOFA score every day until the patient in their example died. So that patient had like 12 SOFA scores. And so which one do we use? And what the Sepsis 3 expert panel stated they did was that they looked at sensitivity analyses with various time frames, looking at longer time frames and looking at shorter time frames to calculate the SOFA score. What it appears that they did is that they considered the start of the infection to be when the patient had cultures drawn and had antibiotics started, and they went back probably about 48 hours before that time and then 24 hours after that time, and calculated the maximal SOFA score. So that appears to be how they did it. Now, in many instances, these patients are coming to the emergency room, and so you're not necessarily going to have the data 48 hours before the onset of infection. So effectively, what you'll end up doing in many cases is calculating the maximum SOFA score during the first day of presentation.
Okay. Let's see. And then there were these other questions. You keep calculating even if the patient's getting better.
Yeah.
I don't know if you want to jump to the recommendations.
Well, I guess I'll just briefly answer the questions on the slide, and then we can move on, unless we're running short on time, Ernie.
No, we got plenty of time.
Okay.
Lots of time.
So So do you keep calculating the SOFA score even though the patient's getting better? Because, for instance, one of the things that is in the SOFA score is thrombocytopenia. And as we all know, thrombocytopenia often develops over the course of infection, but the patient can otherwise be getting better. Everyone's going to have to decide what they're going to do in their own institutions, but all I can say is that in some of the articles that were published, the companion articles, it appeared that they likely used the maximal SOFA score in the first day of presentation. So if you wanted to match what the sepsis authors appeared to have done, then that's probably what you'll end up doing. As far as the PF ratio, those that have looked at the oxygen dissociation curves, and we have a very experienced audience looking through the names. Many people know that it's not hard to have a PF ratio less than 300. In fact, with a normal pH and a normal 2,3 DPG level, and in the absence of fever, an oxygen saturation of 91% on room air actually correlates to a PF ratio of less than 300. But how do you calculate a PF ratio if there's no ABG? Because that would have to rely on converting a partial pressure of oxygen, or estimating a partial pressure of oxygen from an oxygen saturation, and you'd have to make some assumptions about the oxygen dissociation curve for that particular patient. So without an ABG, you technically don't have the P, so you can't calculate a PF. And the expert panel did not actually extrapolate oxygen saturations from an oxygen saturation to a partial pressure of oxygen. And in fact, I think they said in their paper that outside of the ICU setting, that 2/3 to 3/4 of patients actually did not have an ABG. So in their derivations, with looking at the retrospective data, they did not estimate a PF ratio if there wasn't an ABG. But that being said, some consultants have asked the panel, in cases where the patient clearly has a PF ratio less than 300 and you just don't have an ABG, if somebody's, for instance, on a face mask with a saturation of 90%, no matter what the pH is or no matter what the temperature is, that patient's going to have a PF ratio of much, much less than 300. And so can you use that? So, and there was no great answer given to that question. So again, it's something that I think that you're going to have to decide on an institutional level. The last question is what if the organ-involved infection is causing the SOFA abnormality? Like what if, for instance, there's a pneumonia and that's why the patient's hypoxic? If you look at the sepsis definition, you think, well, is the pneumonia, can it really cause a life-threatening organ dysfunction that's not related to the infection itself but to the host response in the lung itself? And how do you distinguish between that? But there does seem to be reasonable consensus from the sepsis authors that they could not exclude the organ of infection causing the abnormality in their derivation data, and so they do not recommend that we exclude that organ abnormality if it's the source of infection either. So basically, if it's a pneumonia and the patient is hypoxic and has a PF ratio of less than 300, the sepsis authors would support counting it.
Okay. Let's move to the, we had somebody asking in the chat box, how then was it suggested to identify the septic patient in the ICU setting?
So in the ICU setting, you would use the clinical criteria and look for a SOFA change of 2 or more in the setting of infection.
Okay.
That would be the clinical criteria. And then experienced clinicians can also continue to use their bedside clinical judgment using the actual definition when they feel that the patient has the life-threatening organ dysfunction related to the host response to infection. Because there's nothing magical about the SOFA score. Remember, the SOFA was just chosen because it was fairly simple and it was correlated with a higher degree of mortality in sepsis. But there was never any guarantee that a SOFA change of 2 or more actually reflects an underlying cellular change in the patient that matches the sepsis definition.
Now, here's that article. I was finally able to find the article that I had downloaded a couple of weeks ago. Where is it? You were mentioning that below is this what you were talking about? Okay.
Yeah, if you scroll down to maybe the 4th or 5th page, Ernie, there's a chart that clearly lists the old and the new sepsis definitions and the clinical criteria. Yeah, a little bit further.
Okay. This one?
Right there.
Okay.
Yeah, right there. So as you can clearly see, the definition is different from the clinical criteria, but the clinical criteria are likely what everyone is going to be using because the definition doesn't have clinical parameters. It doesn't really help you at the bedside.
Okay. Okay, so that's what they're suggesting, or that's what you're suggesting about what you want to be doing is using these. Now, is this different from the current CMS? Because we had a question from somebody earlier before the show, then we had this new one as well during the show. But this is different than the core measure definitions of sepsis that are approved by CMS. So what do we do?
Right. Now, that's correct, Ernie, and it was a great question from the viewer. So these definitions came out after CMS had determined that the SUP1 core measure bundle definitions, which were largely based on the older, mostly actually the 1991 criteria, even more so than the 2001 criteria, they are very different. They are nothing alike. And I'm not a New Yorker, but it is what it is. I mean, they are what they are, and they're both valid, and they're both going to be continue to be used for what they were intended for. We've heard that CMS does not plan to change the SUP1 severe sepsis and septic shock definitions anytime soon. They may even publish something soon. I heard through the grapevine something to that effect, but don't expect SUP1 definitions to change. The one difference, though, that I will say is that Sepsis 3 actually eliminated severe sepsis as a term, feeling that it was redundant, feeling that sepsis already had an increased risk of mortality, and so they basically got rid of the term severe sepsis. So Sepsis 3 defines sepsis, and it defines septic shock. But the SUP1 core measure criteria, they don't define sepsis. They actually let you define sepsis. And the denominator from which the population will be chosen is anybody with an ICD-10 code for sepsis. You know, whether it's sepsis secondary to a specific organism or sepsis due to an unspecified organism or severe sepsis or septic shock, any one of the 30 or so ICD-10 codes for sepsis will trigger that patient for further evaluation in the SUP1 core measure. So you actually decide who is sepsis, and you decide what sepsis definition you're going to use. And based on that definition, if you label that patient sepsis, then that's when the core measure kicks in, and the core measure is then going to apply its own definitions of severe sepsis and septic shock. And if those definitions are met, then there will be requirements that are going to have to be met for core measure performance.
And of course, basically, we've been talking about solely identifying so that you can plan and treat the patient with no regard to, we've not been talking at all about how this is going to affect reimbursement. Bill, I wanted to ask you, because you're in the UK, and this definition, SEP3, was basically from an international community. Do you see this being significantly different anyway from what U.S. providers are going to have to use, because they're the ones where all of this is being used for reimbursement as opposed to
it's not a reimbursement. It's not a reimbursement thing over here. It's a quality measure. And so there are certain quality measures that are specified within the quality measures book, and that's how they're going to be looked at against it. So it's not as gooey as it is obviously in the U.S. with SOFAs, QSOFAs, core measures, ICD-10 definitions. There is one basic concept that leads to the sepsis for quality measures. Now remember, they're not paid over here on fee-for-service directly. They're paid on a quality measure outcome. So the QSOFA and SOFA and that clinical triage and screening becomes more important, would become more important over here based on the fact that it would be early intervention. They're not interested really in paying for long service in the facility. They're looking at early intervention and quality outcome. So it's a whole different ballgame. I guess my question here today is just listening to all this great information, and thank you, Dr. Yu. This is amazing information. If you're a basic auditor under the CMS or the RAC program or what have you, how is this going to play out? I mean, this has been an area of concern for so many people. You know, what is sepsis? What is septic shock? What are the core measures? Who's using what? How does the document, the medical record, going to make it easier to avoid these types of pitfalls with overpayments and all that's going to go along with that? Any thoughts on that?
Yeah, no, Bill, those are great questions, and I do have to say that a couple of the lead authors in Sepsis 3, I believe, are from across the pond. Dr. Mervyn Singer, I believe, practices and runs an ICU in a major hospital in London, and he was actually kind of poking fun at his American colleagues at the SCCM conference that we have to worry about reimbursement and SEP 1 and auditors, whereas they can just take care of the patients. So
yeah,
that's absolutely true. You know, I mean, I don't know exactly how the auditors are going to view the new sepsis definition. I have heard rumblings, I don't know if they're true or not, that the RAC auditors or recovery auditors are already starting to use the newer definition, the Sepsis 3 definition, and looking for the organ dysfunction. I will say that there have been polls done by various organizations about what providers in the United States plan to do with the new sepsis definitions, and basically people all over the place. You know, if you look at, you know, people, probably about a quarter of the institutions plan to adopt Sepsis 3 right away. A quarter of them plan to ignore Sepsis 3. A quarter of them are you know, waiting for further information, and a quarter of them are waiting to see what CMS says about this, if CMS will even say anything about it. And so people are very much divided as far as what they're going to do. But I'm not an auditor, but if I were an auditor, and if I saw an organization still using Sepsis 1 or Sepsis 2 criteria, and Sepsis 3 is now the sepsis criteria that is the most recent, then I think it would be very easy for an auditor to question the use of Sepsis 1 and Sepsis 2. So I don't know that Sepsis 3 should be ignored. Rather, I think Sepsis 3 needs to be embraced, but you also have to keep in mind the SEP 1 definitions of severe sepsis and septic shock. I think we're in a weird situation now where providers actually need to realize that there is more than one definition of sepsis that's in use. And I don't know if we'll have time to talk about it later, but the CDC actually plans to come out with its own surveillance criteria for sepsis that is even different from Sepsis 3 or the SEP 1 definitions of sepsis. So there will be yet a third definition of sepsis that apparently will soon be announced. And they'll all be used for their various purposes, and I think we need to be mindful of all of them. But I'm not sure that ignoring...
This is Sharon. How's everyone?
Hi, Sharon.
Hi, Sharon.
Thank you for joining us.
Yeah, I'm only here for a few minutes, but I do agree. I think that's Dr. Who. And I would say that we as coders and auditors don't know how to meet SEP 1. So, of course, we're not going to know how to meet SEP 3 or 2 or 3. So it's a problem. Sepsis is a problem when it comes to assigning the correct code based on the clinical indicators and the documentation in the chart. It continues to be a challenge, and I think this just brings even more of a challenge because all the time we've had this criteria for some time. There are lots of denials because we are signing sepsis inappropriately, and that will continue to happen.
Yeah, there was somebody, you were 69, saying that they've already seen SOFA requirements be used in denials by third-party payers. She said they were retrospectively denied for October and November 2015 admissions using the SEP 3 information, which I find that ridiculous because SEP 3 didn't even exist in February.
That's absolutely going to be their first line of approach. The commercial managed cares are going to go with a thing that they're going to try to get their money back. Now, here's the key to this. Remember, commercial managed care is a contractual issue. And it's very easy to write into your contracts as amendment that you are using Sepsis 3 definition, or you will use Sepsis 2. You can't do that with CMS or Medicaid. They kind of do what they do. But when the commercials are, you're supposed to be a partner in this negotiation. And it's always best to put as much information into that contract. Now, they're not going to really care. If you tell them you want Sepsis 3 and they're going to say Sepsis 2, that's fine. It's now documented what you're going to use. The key here is, like the British people said over the pond, they take care of this patient. And then let's figure out how to get that electronic medical record to review Sepsis 1 or Sepsis 2 or 3 or whatever it is you're going to be using. But to try to get these docs, these poor docs, to figure out, I'm on Sepsis 1 for this and Sepsis 3 for that, that's a nightmare. You just need to have them document and take care of the patient, figure out the rest around it. What is going to support all this in your electronic medical record that's going to give that definition out to whomever?
Absolutely.
Yeah. There's some comments here by Dr. Prahuja I want to read in. He's saying SOFA performs better among ICU patients. However, clinically, the definition of sepsis is mostly useful outside the ICU. That is, identifying, for example, identifying patients who require ICU transfer. And then he also wrote that Sepsis 3 has, up to this time, been endorsed by the Society of Critical Care Medicine, the American Thoracic Society, American Association of Critical Care Nurses. However, it has not yet been endorsed by the American College of Chest Physicians, the Infectious Disease Society of America, or any of the emergency medical societies, or any hospital medicine society. So it's difficult to call this a consensus guideline without the support from emergency physicians and hospitalists, since they are the ones who diagnose sepsis most often. So I think that it adds up to this being, this is a pretty difficult situation right now, at least. And I do think that Bill's suggestion is critical, that you talk to your contracting folks and try to get whichever guideline it is that you want to use. You want to use the ones that CMS is using and just use that hospital wide, which sounds like a good idea to me, because it's less confusing for everybody. Then you can do that and treat the patient and then just deal with the Sepsis 1 documenting according to that. Now, and we've talked about that in the past on previous shows, and I'm sure we're going to talk about it more in the future.
Ernie, I want to stress, I think the key to some of this defense work, and you're going to end up defending it. Of course, they're going to say deny, deny, deny. That's what they do.
Yeah.
But I think in defending it, part of the defense is the community standard. Part of the defense is, did you have it documented in policy and procedures? Is this consistently applied? Or did you use it just on our patient? Part of this whole defense of sepsis, because it is so gooey, is having your organization on a solid platform. What is it you're going to do? Who's going to do it? So you only have one coder coming up with one thing, one another. Your electronic medical record with all these smart phrases and smart templates, you could literally be documenting the same exact thing by two different physicians and come up with different presentations in the electronic medical record. So you need to avoid things like that. So what is it you're going to say? How are you going to – because ultimately this is all about treating that patient.
Right.
And I look forward to the day we move from into quality and away from fee-for-service, but I don't think that'll be in my lifetime. I'll just have to stay over here.
Well, and I think it's very impactful what Dr. Prahuja said, because he says it's not endorsed by the emergency medicine physicians when QSOFA is kind of implied to start the process there. So I think that's an impactful statement that he just made.
Yeah, no, I mean, it definitely is true that the sepsis authors actually were asked that question at SCCM and asked why they did not include, the one that they singled out was the American College of Emergency Physicians. And they basically said that they did not actively exclude anyone, and that I think they have 15 international societies that support the Sepsis 3 definition, but there are some people that have not supported it, and the American College of Emergency Physicians is one of them. the corresponding body, and Bill, you may know the official name, but the emergency medicine physicians in Europe do support Sepsis 3, so there is some support from the emergency medicine community, but not necessarily the major emergency medicine community in the United States.
Just as a layman looking at this,
that's not just a British thing, that's more of an EU thing. You've got Germany and France, Netherlands, all in that same ER group, or ER grouping. So they do represent, and usually if one of the countries or several of the countries back a model, they all tend to back the model. The difference being the Ukraine, Poland, and Russia, they tend to have their own models.
There's one thing that to me seems, as a layman, not a physician or I'm not clinical at all. It seems to me that there's good reason to look at QSOFA in the. Oh, wait a minute. Now, was it? I forget which it was. Now, is QSOFA better in the ED or in the ICU? Well, one was better in one, and one is like 10 times better in the other. So does that mean that it's really a good idea to use both?
QSOFA is essentially equivalent to SOFA outside of the ICU, but it's inferior to SOFA in the ICU for the reasons that we mentioned before. But QSOFA does not require any laboratories, and so it's the first thing you're going to be able to do when that patient appears in your ED. And the purpose of QSOFA is early recognition of the patient that has a high rate of doing badly, so that aggressive interventions and monitoring and admission to the ICU, if necessary, can be recognized early and performed. But the problem with QSOFA is that they just derived this criteria, and even though they looked at derivation samples and validation samples, there actually is no prospective validation of the QSOFA because it's brand new.
Right.
So that's one of the things they're really eagerly looking at. I mean, if you hear them talk about QSOFA, they are really very positive on QSOFA. They think it's going to be great. They think that they're going to be able to elevate the importance of QSOFA in the future once they get additional data. But the Sepsis 3 definition does not actually imply any treatment changes. I mean, with sepsis, you still have to treat hypotension with fluids. You still have to treat elevated lactates. You still have to do the early and broad-spectrum antibiotics. You still have to do pressors if somebody isn't responding to the fluid challenge. None of those things have changed. All the things that were in the Surviving Sepsis campaign documents from 2012, many of them have been prospectively validated, some of them not, and so some of the things we don't do anymore. But many of those things are still the guiding treatment principles for sepsis, and all that Sepsis 3 really does is it helps you identify some of those sicker patients, those patients who have a higher risk of doing badly, because that's how the clinical criteria were developed.
Okay. So, and that kind of fits. Go ahead, Sharon.
And as I mentioned on another show as a follow-up to those comments, that it puts a population of patients into a, quote, potential population of sepsis patients. How is that going to be documented in the chart? How does that continue to be documented or ruled out through the stay? And how are we going to use that information in final code assignment? What's going to be our strategy for that? You know, we want to make this early identification, but from a documentation standpoint and coding standpoint, how do we handle that and how does that play out? And that's where the fear is that we're going to be assigning something that may not be a true sepsis. So it's going to strategically take people within your organization to make those decisions. And that should have been something that was being done all along.
Okay.
Well, Sharon, you are the professor on that subject, and we are the choir. But like any general coding principle, the providers have to clarify whether something was present or not present. If they raised the question earlier on the hospital stay, they should either rule it in or rule it out. Exactly.
And there was somebody
who does become important when documenting that reason for admission. You do have more credible. It's something that you can say to the auditors and whoever, look, this was a reason for admission. It may not be adopted by everybody, but it is a community standard. People are using it. And then that SOFA score might help you also in defending the admission because, obviously this is going to get into an ugly to midnight thing. So anything that you can do along this regard is, of course, helpful in defending yourself because I still think that most of the auditors, including myself, struggle with sepsis. Is it, isn't it? What's it look like? How's it documented? In the thousands of pages we're going to get, how do we make it useful to the end reader for payment?
And then there's viewer 78 commenting, if hospitals are using different definitions for sepsis, like they're using 1 and 3, then the core measure data is not going to be apple to apples, right? I do think that's a concern.
Yes and no, Ernie. There is a chance that it may not be apples to apples because the only way that a patient even gets evaluated for the SEP1 core measure is if that patient has a sepsis diagnosis on the claim. So if now all of a sudden you are diagnosing a completely different population with sepsis or excluding a large population of sepsis that you used to call sepsis, then it is possible that you won't be comparing apples to apples. There was some work done to look at if you apply the SIRS definition, SIRS-based definition of sepsis, or versus the SOFA-based clinical criteria for sepsis, how well do they match? And the result was that there are slightly fewer of the SOFA change clinical criteria for sepsis patients than there were SIRS, but the difference is not as much as people may think. So I think it was about 2/3. The SOFA population was about 2/3 of the population identified using the SIRS, and so the majority of cases that you used to call sepsis by using the SIRS criteria, more than half of them are still going to be septic using the SOFA clinical criteria. Once you label that patient with sepsis, then whether that patient is included in the SEP1 core measure is entirely dependent on whether the patient meets the CMS severe sepsis definition. So once you're in that bucket for evaluation, the only patients that are included are the patients that meet the SEP1 severe sepsis definition in the data dictionary. So once you get to that level, then it may be apples to apples because then everyone will be applying the same criteria because they will be the CMS criteria. Okay.
I see. Let's go ahead. We've only got a few minutes left. I want to make sure we get to these recommendations that Dr. you put together. These are all in his article, by the way, but I wanted to give him a chance to speak to them just for a few minutes here before we end the show. These were what you considered reasonable recommendations after talking with lots of people, plus some people on the committee, and trying to deal with, there's no real answers coming out of anybody, but these are what you would say are common sense recommendations. So why don't you go ahead? I think we've got 3 slides of these, Dr. Yu.
So I think that the time frames and the best average of worst scores, I think we already mentioned. Time frame, I think most people are going to end up using probably the first 24 hours of presentation. That appears to be what the Sepsis 3 authors used. You would use the maximal SOFA score, the worst SOFA score. That also appears to be how SOFA was originally derived and what the Sepsis 3 authors used. Okay.
So let's go to the next one.
Slide, Ernie.
Calculating once or daily and oxygen sat.
Yeah, so you generally will calculate it once using a whole day's worth, generally the first 24 hours worth of information. Oxygen saturation, I don't know what to tell you. I mean, I can clearly see that there will be patients who have a PF ratio much less than 300, but they don't have the ABG, and I don't have a great answer for you. You just have to decide as an organization whether you're going to count that or whether you're not going to. I know some organizations are planning to, some consultants are planning to use this because it actually is very common, and it's not unreasonable in the lack of more specific guidance from the Sepsis 3 authors.
Okay. And this last one, infected organ contributing to SOFA score. Should you count it? Yeah. And the authors apparently support this idea.
They do. We didn't poll every author, but the few that were polled supported the use.
Okay. Well, that's then the basic takeaways I'd say from the show today is make sure that you are able to explain what the clinical criteria that you're using, and like we showed in that, there are clinical criteria in Sepsis 3, or you can use the others that are from the quality scores, but you're going to have to be able to explain what it is. And like Sharon was saying, and Dr. Hugh was saying, pick your method and stick by that, and make sure you get everybody informed, at your facility or clinic about what you're doing and how you're going to do it. And then whether or not you're going to use SOFA or QSOFA or both, it's kind of up to you, because this is all so new. QSOFA is so new, nobody knows. It looks like it's going to be a great tool, but that may or may not pan out, and the emergency organizations seem to be not yet jumping on board with that. They have great hopes for it, but who knows at this point. Anything I missed there, Dr. Yu? Any last words before we close up here?
No, that sounds great, Ernie. I appreciate the opportunity, and I hope that the viewers found this helpful.
Oh, I'm very sure they did, because this is exactly the kind of stuff I know they were asking to hear about. So I really appreciate you jumping in with us and giving such great information. And it was great to have Sharon on for a few minutes, and Bill. As a matter of fact, I am going to have that webinar with Sharon about ambulatory CDI up by next week. So that's what we'll be doing there. Basically, that's all the time we have this week. So
Ernie, I just wanted to double check where we might find all of Dr. Hugh's good information, his articles, what have you.
All right. It's on the ACPadvisors.com.
.org.
Yeah. Oh, it's .org.
www.acpadvisors.org.
And then his article. Yeah, it's on the featured article archives. If you go there and look for that link. So, and I did on the previous show, I believe I showed the link and actually sent out a copy of it. I'll see if I can send a copy of it. Would that be all right to do, Dr. Hughes? Send a copy to everybody who was...
Absolutely, Ernie. Or if you just want to put it on your Finally Friday website, that'd be fine too. Great.
We'll do that. Okay. Thanks, everyone. We'll be back live next Friday, April 29th, with probably a special presentation about the IPPS proposed rule. That's the plan, anyway. But I'm not absolutely sure, but watch for my email announcements. Also, you want to watch for my announcements about Sharon's new webinar. And thanks to everybody for participating today. Special thanks to Dr. Hugh for sharing his knowledge and experience with us all. And also thanks to everyone who participated in the chat box today. It was somebody saying, yeah, as a coder auditor, it's clear as mud, but it was quite informative. I get it. Yeah, it's a difficult situation right now, but we're doing our best to try and help you out. Of course, thanks to all our sponsors and partners, the Health Law Partners, Meddlings Cost Containment, Mass Coding Solutions, Recovery Analytics, and the CCMA. It's their contributions that make these broadcasts possible for you for free, folks. You should thank them. Visit their sites. Watch for my emails about next week's show. Share the links to our show with your colleagues and friends. And the last thing I want to share with you, because it's so inspirational to me, is this quote from Prince: "Whatever you're doing, level up." I think that's tremendous advice, a very inspiring life, a very inspiring quote. And that's all we've got time for today. So we'll see you next time when it's finally Friday. Have a great weekend, everyone. Bye-bye.